Wales. And so I'm going to talk to you this afternoon about some of the shared challenges that we have in Scotland and Wales around providing wound services. And some of the ways that we've tried to operationalise and make the best use of our limited DXA capacity. I also want to talk about ways in which we've shared some examples of ways we've tried to optimise care across the whole care pathway to support action, and just a little bit about how we are trying to use our local data as well to understand the impact, feedback and improve care. So, why is this a shared challenge? When people talk about the UK, they refer to England and sometimes England and Wales, but as you well know, healthcare is evolved across the nations of the UK, and Scotland and Wales are, and the healthcare system, for example, in England is very different to Scotland, but actually there are quite a lot of similarities in the way our healthcare is set up in Scotland and Wales in our devolved systems. We both have very large rural populations, and many people have long distances to travel and unequal access to care. We have increasingly ageing populations, and we share this problem of having limited DXA capacity and resources. And we've heard a lot of talk today about moving from talking about patients to persons, to people living with conditions. And that's really sort of mirrored in our approach of Scotland, which is around realistic medicine and this value-based health care, really around thinking how we can improve access to healthcare and using tests and treatment where they add the most value. And I know there are policy makers in the room. Policies are not always that helpful, but realistic medicine, I think, has been a really useful principle that has resonated with clinicians, not just in Scotland but throughout the UK, and really how we can share decision making and where we can use our testing treatment to add value. So what I want to do in the next few slides is just look at some of the All Wales guiding principles around referral for DXA and how we try to operationalise that within our service. I think the first thing to say is our service is not perfect by any stretch of imagination. We use Excel spreadsheets. We don't have end-to-end digital offering, but we try our best. I think it's also worth saying that our fracture liaison service sits within our own service. We cover 3 health boards. We cover Grampian, Orkney and Shetland, which is a population of around 600,000 people. So, one of the first All Wales guiding principles is around DXA, who to refer for DXA. Talking about adults with risk factors, into high risk of fracture, supported by FRACs or clinical judgment. And what we're trying to do in Grampian is make it really very clear, develop local guidelines based on evidence around indications for starting treatment before DXA scan. For example, if someone's had vertebral fracture or someone with the age of 65 with steroids, recognising that in the best world in the world, they're going to have to wait for a DXA scan. And we also give indications clear indications for using DXA scan, risk factors and FRAC score, and working with colleagues to take into account the specialist society guidelines as well. And we also actually try to indicate where DXA is not routinely indicated. But that's not saying that please don't get in touch with us and to discuss things, but we've tried to make this as clear as possible, and this is embedded across what's called Grampian guidance, which all our GP practices can access. So the next All Wales guiding principle is around DXA should be considered of lower value where the result is unlikely to alter patient management. And you've heard earlier about giving zoledronate for patients, in patients with fracture, and my former colleague else black, who is happily in retirement, was part of the Foundation's consensus on the use of Zoll after hip fracture. And so we have implemented that. It's not been without its challenges, I think it's fair to say, but certainly we do aim to give all patients where possible who have been admitted with a hip fracture physical injury during their hospital admission. Recognising that many of these people are older and are frail or in a nursing home, and practically bringing them back for subsequent infusions is very difficult. We agreed with our geriatrician colleagues that in those cases we give them a one-off infusion. And it's really about trying to avoid treatment delays when avoiding delays when the treatment decision is already clear. And we're trying to balance the evidence, frailty, and our local DXA and infusion capacity. I can talk at length about the challenges to embedding this, not least anxiety around the dietitian. We've worked really hard with our orthogeriatric colleagues to allay these fears. And also, as Professor Speed referred to earlier, how do we identify, there's also this tension, how do we identify people who could potentially benefit from anabolics as well? And then we're thinking about how do we prioritise repeat DXA scans when we have limited capacity. And the All Wales Guiding Principles suggest that earlier rescanning should be considered only where the result is likely to change management. So we certainly try to follow that approach, really where it's going to change treatment, if they've got an adequate response or a new fragility fracture. We're increasingly using anabolics as first line in patients at high risk of fracture, and certainly, assessing response to anabolic therapy and planning sequential treatment is really important. I think it's really important just to remember that part of that assessment isn't just necessarily a rescan. Are they taking the medication? It doesn't work if you don't take it. Is there anything else going on? And reassessing fracture risk. And also that just stop think when you're reporting DXA scans, reducing routine scanning, repeat scanning is not going to change management. For example, patients on lifelong denosumab, the DXA result is not going to change management. Where I want to move to now is a subject very close to my heart because I'm a health service researcher, is around the optimising the care pathway. And the DXA scan is only one part of that. We need to have, we need to get people referred into the service, they need to have access to it, we need to act upon it, and we need to evaluate what we're doing. And we've worked quite hard to widen our referral routes in. Many more healthcare professionals can refer into our service, our EHPs, working in geriatrics, in primary care, in fall services, our specialist nurses within the breast cancer service. So we've tried very hard to work across that. There's been some hiccups along the way. We did have a tsunami of referrals from the fall service initially, who decided to do a FRAC score on everybody with no risk factors for osteoporosis, and we got a lot of referrals for 90-plus-year-olds with who had a high FRAC score simply based on their age. But we sorted that out. I think being able to support clinicians to know who, when to refer and signpost to resources is really important. And I know there was a chat earlier about radiology reports, and we've had some success with that locally, and we work quite closely with our radiologists, and we persuaded them on their X-ray reports. This is an example here, the grade 2 wedge compression fracture, one identified. We persuaded them that if they saw that, all they needed to do was say fract code word, and this would automatically appear in the reports. And that actually increased our referrals to our service by about 25%, simply by having that written, which is quite amazing really, because people were clearly reading the X-ray report and acting upon it. And then it stopped, and then the amount it fell off, and I had to have a conversation with one of the radiologists who said, yeah, well, we're not really sure 500-mile round trip to Aberdeen for a DXA scan. People just weren't coming. And so we set up a mobile density scanning service. We've evaluated it. We know it captures older, frailer people who were just not having any access to services. And it's much more than just the access to the DXA scanner. It has a huge impact in terms of awareness, and it's about bringing the whole service to the patient. As I say, it is on its last legs. The Scottish Government have agreed to replace it, which is good. It's not going to be mobile for much longer. I think it probably is the only DXA scanner I'm aware of, maybe in the world, that actually goes on a ferry across the North Sea and survives. As long as you keep Mobley warm, they're happy. It works. This is probably one of the most important slides that we produce and had the biggest impact. So how can we ensure that our recommendations are acted upon? So we write a nice individualised DXA report, and we look at the patient's CPR, and we make suggestions. Do they actually get the treatment? Well, this was really sobering. So we have linked our fracture rating database to community prescribing. And we found that just over 50% of patients who were recommended a bisphosphonate treatment had received at least one prescription in 1 year. And we were sending out concordance letters, but for complex reasons that I don't have time to go into, these were only being sent to the patients initially, and it clearly wasn't working. So we actually showed this data to our administrative staff. So this is a really important part of our team who often get neglected. They do a huge amount of work. If we had end-to-end digital, that would be great, but we don't. And actually showing them that data made them think, oh, hang on a minute, actually, we do really need to work to make sure that these letters can actually go out and get copied to the GP practice as well as just to the patient. And they're often being actioned now by community pharmacists, and that's been hugely helpful because our treatment rates have gone up significantly. We've also done quite a lot of Q&A sessions with our community pharmacists. I've got here dispelling the middleman myth. I think we established that there was no orthopedic surgeons in the room, is that right? Yeah. So one of the things that it seems to be a real block is for them to think about bone health or refer somebody, is that they're really worried that they'll have to act upon the recommendations. And we copy all our DXA scan reports to the GP, and we make it very clear that these are recommendations for the GP to prescribe. And our community pharmacists are very, very good at acting upon that. Finally, I just want to touch upon how do we know whether it works. And I've talked about evaluation really underpins our approach. We've got around about 30,000 patients now in our FLS data set from 2014 to 2024, which has actually been put into our data safe haven, linked to outpatient, inpatient prescribing, deaths, etc. And that's a hugely helpful resource to be able to evaluate and feedback. I'm mindful of out of time, so I'm just going to give you a few take-home messages. It's all very well to make best use of our current capacity and to make pragmatic decisions, but we do need to improve equitable access to DXA. We need to use it where it is adding value to care and not delaying treatment where the decision is already very obvious. And we need to design the right whole pathway or better outcomes. And the referring, the reporting, the follow-up and the evaluation matter as much